Apocrine tend to look a little bit bigger, and you can tell the difference because do you see how they, on here, these eccrine, they actually open straight to the skin, where if we have apocrine, they tend to open into a hair follicle. You'll also notice in there that we have what are known as corpuscles. So when we talk about nerve structures, there are different nerve structures that we're looking at. And you can see they begin with are the sensory nerve fibers, and they have free nerve endings. And you can see how they kind of go in and they become a little bit more superficial. Let's look at the main three corpuscles. And so we have ruffini, which are also known as bulbous corpuscles, and they detect tension. And they are generally found deep in the skin. And then you have Merkel disc or nerve endings, and they help to detect pressure. And this is sustained pressure. And then you have what we saw there, which are Pacinian, which are also known as lamellar corpuscles. And they help with basically rapid vibration. So when we look here, these tend to be more kind of elongated when we look at them. These tend to be kind of these rounded, but they're pretty big. And these tend to be a little bit smaller. Now here, you tend to find these two both in the dermis and a lot of times with these tend to be the deepest, and they tend to be either in the lower dermis, and they look very close to being in the hypodermis. Now you also have, besides Merkel, you have Meissner corpuscles, and these are basically very close to where you find the Merkel, and they're considered tactile corpuscle. So these are not as low into the area as the lamellar, because these tend to have basically fine sensation. So kind of small sensation to touch and vibration. So the first thing that we're going to look at here are the different layers. And so we're specifically looking at epidermal cells and layers of the epidermis. And you can see here is where we see the dermis. So this is that basement membrane that we find. And this is where you're going to see the stratum basalli, or basal. And this is the deepest epidermal layer. It's about one row of what we considered actively dividing cells. And so that's why we talked a little bit about mitosis, so you can understand what that means. Some of these new cells will become part of a more superficial layer as we go through. And then occasionally you'll see melanocytes and dendritic cells here as well. And we'll talk about what those are. And so then you can go up. And so this is this area that you're seeing right there. And then we go up to this next layer there. And that's what's known as the stratum spinosum. And so we have several layers, and this is where you're going to get the cells that produce keratin. And they come together, they're united by those cells that bring things together known as desmosomes. And they consist of thick bundles of also intermediate filaments here that are made of a protein that is a precursor to keratin. And so you can see that we have that from about here to here or here to here. You can also see the dendritic cell that you can see there. The next thing we have is stratum granulosum. And typically this is 1 to 5 layers. You can tell that they're there because if you look here, you can see all those cells are starting to become really flat here. And so the cells are still alive at this point, but they're starting to deteriorate. If you notice, we're getting, here is the area that has all the blood vessels. So we're getting farther and farther away. And basically everything here, all the minerals and nutrients are moved through diffusion. So the farther it gets away from that dermis, the less likely it is to be able to get the nutrients and the substance they need to survive. And so they're going to start to deteriorate. And then you can see all of these. These cells are all the most superficial layer. There's 20 to 30 different layers and all these cells are dead. And this is the stratum corneum. And so you're going to see they're basically just cells full of keratin. And that's going to help with the protection. And so you can work on this to see, can you figure out what those different layers are here? Now, I will notice in there is between the corneum and the granulosum an area called the stratum lucidium. And this is kind of more of a waterproofing area, and this is only in thick skin. So we have this on the palms of your hands and the soles of your feet. And that's what makes them kind of that thicker layer. So the first cell type that we're going to talk, we talked about the cell that produces keratin, but now we're going to talk about the cell type that produces the pigments that allow for the different colors that we see in the skin and even in the hair. So these are what are known as melanocytes, and they're in the stratum bacellae, and they contain specialized organelles. They're called melanosomes, and they actually produce the pigment known as melanin. And melanin is important because it provides skin color, but more so that skin color is there to help with the protection from UV radiation. And so it helps absorb. So coloring will be different based on location on the earth due to the amount of sunlight, that ancestral speakingly is where that comes from. And the melanin is actually transferred to other cells by the cytokine secretion. So that's why we talk about that in the last lesson. And so you can see here that you have, in this area, you have the melanocyte nucleus that's there, right? And so what that is actually doing is, and then you can see all the Golgi. So it's opening up around, and you can see that it kind of moves and has these branching that comes out that goes around all these different epidermal cells that you see. And then essentially it's going to release the pigment granules into, and then the cells are going to take those up. Now there are different colors. And so let's talk about the different pigments that we have. Eumelanin is actually, there are two types, and this is where you get the black and brown pigments from. And so this is the darker color in skin, eyes, and hair. So if you have brown or black hair or brown or black eyes, this is a pigment that is responsible for that. Now, if you have no black eumelanin, but only a small amount of brown, That's what equals into blonde hair. So basically, a lot of this is all about the different levels of the pigment that you produce. Pheomelanin, there's two types of pigments. This is the pigment that you see in your lips, nipples, and other pinkish parts of your body. And so if you have equal parts of these two together, then that's where red hair comes from. And so these over here are both important things that you see. And this one is important for responsible of the color of your neurons. It's kind of cool. I really won't ask you anything about neuromelanin because it's not really important in this topic. These are the first two are what I kind of focus on. So when we talk about skin color, that is determined by heredity, ancestrally, right, as well as by the environment and physiological factors. So when we talk, let's start with heredity. So everybody has the same number of melanocytes. And so when we talk about that, we're looking at about 10 to 25% of the cells in the deepest epidermis, right, produce melanin. And the amount of melanin produced is what determines skin color. And like I said, it's there to help protect against UV radiation. So when we talk about this, different skin color is because of the different amounts of melanin produced. And so this is regulated by genes. And also the presence of keratin and hemoglobin. And so if you've ever seen somebody that has albinoism, and that's where their hair is white and their skin is really, really pale, almost pink, and they may even have very, 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 very like reddish eyes, very light eyes. This is a mutation in a gene that causes this. And it's specifically a melanin gene. Now, so we know there's this very specific part of heredity that deals with this, but there are also environmental factors, and I'm just going to put EF for that. So we know that sunlight, UV radiation, and X-rays can cause changes in the skin and changes in skin color. And how this works is it essentially darkens the existing melanin. But not only that, it also stimulates the production of more melanin. And so we get more of that. And well, we get an undergoing of cytokine secretion. And there's the last one that we're going to talk about here. So now let's talk about the physiological factors. And so if you have a increase of blood flow to the skin, it can actually cause a pink color. And so that is, and so this is for lighter skin tones, right? And so this is what's called arrhythmia. Now in darker skin, this can be a lot harder to detect in darker skin types. So sometimes, and this is where it's really important to be able to advocate for your patients and make sure that you are looking for signs, because you can mistakenly minimize the disease that's causing issue in patients that have these skin color changes, because you have to be more apparent and know what this looks like. And so you can see kind of a purplish hue. It may even be gray or a darker skin color. And so where you might be able to see this in someone with a lighter skin color, where you get this pink or this reddish that's happening, that you really do have to realize that depending on what kind of patient that you have in terms of their skin color, you have to be aware of what these things look like. Now, you also have cyanosis. And this is a lack of blood flow to the skin. And so in someone with lighter skin, you're going to see blue tints. And so when you look at darker skin, you may not be able to see this coloration necessarily in your hands or around the face. So you kind of have to look in different areas, for instance, in the eyes. Or in the palms of the hands. You might see a bluish tint there. Another place that you can look here is looking around the lips or at the tongue or even in the nail beds. And in this, you might see a grayish white color. And so this is the same that you would look at for, say if you're looking for paleness. Right, and this is where you're looking at conditions that constrict blood flow. So in some, in lighter skin, you might end up seeing a whitish. And then in this case, again, you have to look at these different areas and look, do you have grayish to white color skin and around the lips and the tongue and the nail beds? Because that's where you're going to be able to see it. And then the last thing that we're going to look at is you can see jaundice. And this is a liver malfunction. And in here, you can, in lighter skin, the skin actually turns kind of a yellowish kind of color. In darker skin, what you'll want to do with this is you may not be able to see the minor changes in the skin color or the yellowing that is noticeable there. So you want to look into the eyes and look, and this is something that you can do with anybody, is look kind of at the whites of their eyes and see, is that area turning yellow. You may be able to see it in kind of the areas that are lighter of the skin, but this is kind of a way that you can double check this. And I'm kind of going through this, make sure, because to be the best advocate for your patient, you really need to be able to see the signs, not just for one type of person, but for everybody, and to really follow up on those things to make sure that people are safe. So let's talk about the dermis now. This is a strong, flexible, it's made of strong, flexible connective tissue. There are a lot of different cell types that we're going to talk about. We do have fibers in that matrix that kind of help to keep everything together. And it's the analogy that I can use is that it's basically like the hide used to make leather. And they do have alloderm, which is used to replace epithelial tissue when they do reconstructive surgery. It does contain nerve cells, blood, and lymphatic vesicles. It also has the hair follicles and the oil and sweat glands that we talked about. And it has two layers, the papillary and reticular area. And so we've kind of already gone through this, so I'm not going to do it again, but you can definitely see those two areas. That is the reticular or papillary area, and this is all the reticular area. And so you can easily kind of see the difference too, because that papillary area is going to be where the dermal papilla are up here, right around there. And you can see that it's mostly that area. And then when you start getting all these kind of different dysregularities, or here is when you kind of get to that reticular area. It's a little bit easier to see down there. And so when we look at that papillary area, it does have areolar connective tissue that has the collagen, elastic fiber, reticular fibers, and blood vessels. It does have loose tissue that's in there. And so when we talk about those macrophages, we're looking at, or even those dendritic cells, the Langerhans, we're talking about those cells that can help to basically ingest and destroy any kind of microorganism that gets there. So they are there to help kind of patrol and keep that area clean and safe. Now, there are those dermal papilla that are the superficial peg-like projections that we saw. And they're important because you're going to see in that area, they normally contain capillary loops, but you're going to also see that they contain those Meissner corpuscles, those touch receptors, Pacini corpuscles, which are the pressure receptors. And you're also going to see in that area that they will have some of the free nerve endings, those pain receptors. And they're also important because in thick skin lie on top of the dermal ridges that cause what are called epidermal ridges. And so in here, the epidermal ridges aren't so important because they allow for friction ridges. So if you think about this, if you look at your fingerprints on your hand, right, that's what we're talking about. And so that's what's important for fingerprints. But the reason why we have them, it enhances your grip abilities, and it also contributes to your sense of touch. And so we're going to look at these in more detail when we get into the lab, right? But you can see those are the openings of sweat gland ducts straight to the fingers. And so you can look at those. If they're opening straight from the actual duct, remember it's eccrine. And if it's not, then it's going to be opening into the hair follicles, which is what we're not going to see in this area, right? So these are going to be eccrine sweat ducts that we're going to look at here. And then you can actually see the ridges, and the ridges are what are going to be responsible for fingerprints. Now, in the reticular area, this is most of the dermis, right? And so here we're going to have the dense fibrous connective tissue. You're going to have elastic fibers that allow for stretch and recoiling here, but you're also going to have collagen fibers because we need it to be strong and resilient. It's going to help bind water. And in this area, we're going to see cleavage lines. And that's because most of the collagen fibers are parallel to the skin's surface. So you're not going to be able to see these externally. They're not visible, but surgeons know about these. You're going to find out about these because it's important for surgery. And so you want the incisions to be parallel to the cleavage lines. And then what's going to happen is that's going to allow less gap, and then it's going to heal better. And so these are the cleavage lines that you find in the reticular dermis. And when they do surgeries, they're going to cut parallel to these lines, not perpendicular. So they're going to cut. So if you have, say, some kind of knee surgery, they're going to want to cut this way, right? So that they can be parallel with them, or they're going to cut on the leg this way, they'll heal better, or kind of this way, right? And so anywhere they do surgery, they want to kind of, if they can, do the best that they can to essentially follow these lines so that the healing is easier. Flexure lines of the reticular layer are dermal folds at or near joints. So this is where the dermis is tight and it's actually secured to deeper structures. And so that allows the skin's inability to slide easily for joint movement. And then you'll notice that in these areas, that's where you're going to get those deep creases. So you can see it on your hand, you can see it on your wrist, your fingers, your soles of your feet, and your toes. So if you look at your hand and you look at where palm readers generally say, they look at your like your lifeline and all that, that are what are called flexure lines. And so they can show them really nice here in that picture. So let's talk about ulcers. And we are almost done with this section. And so we have decubitus ulcers. And what are those? Those are a disease that affects the epidermis, right, of the skin. And it comes from prolonged pressure. So what this causes, basically, you have a pressure to an area of the skin and it cuts off the blood supply. Right? And so there's no blood supply, right, to the actual skin. And then what happens is it starts breaking down these cells, right? And so these are basically open wounds. And it's basically, it cuts off the blood supply. So that kills the cell's ability to divide. And that breaks down the epidermal tissue. And so what can prevent this? Think about it, movement. So most of the people who get this are people who are bedridden. That's why, especially if you go into some of the places where people are either prolonged in the hospital. So some of the nursing homes, right, where people can't get around. But nurses will come in there or assistants will come in there and they'll constantly move individuals. Even if they can't move themselves, right, they'll move them around. Because anything that kind of has skin that's overlapping, bony projections, think hips, the heels of your elbows, shoulder, your shoulder blades, right? All of those can be subjected to this because there's going to be pressure in the bed. And so if they're there prolongedly, they're not going to be able to reproduce. So they're going to get these open sores. So moving, changing body positions is how you prevent this. That's why it's so important. And so one of the last things we're going to talk about for this part 1 is skin cancer. Basically, skin cancer is generally caused by overexposure to ultraviolet radiation or frequent radiation. There are other things that can cause this, right? There are chemicals that can cause this. My mom had squamous cell carcinoma. And so you can see here, this is squamous cell, right? And she had this on the inside of her mouth. And it was caused most likely from cigarette smoke. And don't be misinformed that makes you think just because you have a dark skin tone that you can't get these, right? The melanin helps to protect your skin some, but prolonged UV exposure in the sun can cause people with darker skin tones to also have these different types of skin cancer. So that's why I just warn that, because there's kind of a little bit of misinformation about this. So there are 2 types. You have the cutaneous carcinomas and the cutaneous melanomas, right? And we're going to talk about those. And so in this picture, you can see we have both the different types. So basal cell, you can think that basal membrane, right? And squamous cell. And so we know both of those. And so carcinomas, these are both going to originate in epithelial tissue. This is the most common type, both of these. As in carcinomas are. You're more likely to get this. The people that get this are over 40, light-skinned, and exposed to sun. You'll normally notice if you look, they tend to be reddish in appearance. They're hard, they're dry, and they're generally scaly. Now, for darker skin tones between these two, the squamous cell tends to be the most likely for carcinomas. And so in here, a lot of times you're going to see that they're kind of a darker skin tone. They can actually be kind of purpley red. And they're still going to have that kind of hard, dry, scaly appearance. So now let's talk about melanoma. And these actually arise in melanocytes. These are not as common. Only about 4% of all cancers are melanoma, but 80% of the people who die from melanoma that metastasizes, which means it goes to different parts of the body. Now, when we look at this, a lot of times, depending on your skin color, kind of depends on where they're more likely to be found. And so in light skin, the idea that most people think of is that you normally see them on the backs or limbs from an existing mole, and then it starts to spread horizontally there, right? And then it spreads horizontally. But when we look, and this is why I mention this to people, when you look at melanoma in people of color, they often occur on areas that are less exposed to sun. 60 to 75% of tumors arise in the palms of the hands, soles of the feet, and under nail beds and or the nail area. So that's why I like to point this out, because if you're taught in your class that most of these, because they generally do when you look at people that have lighter skin, they tend to come from high, kind of this short exposure to high intensity sunlight. So if you think about it, like sunburns that you get that are blistering sunburns, right? Really bad sunburns. And you're like, okay, but then you have a whole other group of people that is not what they always see. And so to be a good doctor or nurse, you need to be able to look at these kind of things, or even to be, say your family is has people that have darker skin tones in them. You want to be able, if you see something, to be able to help and recognize and say, man, you need to go get that checked out. That doesn't look right. Now, what we can do is, no matter what your skin color is, you can apply what's called the ABCDE rule to look at this type of cancer. So let's go through those. I just think it's important, because I know when I went through and looked at some of this, and they never really talked about how do you see it in people that don't have lighter skin tones. And then I started thinking, well, we really need to talk about this, because you can potentially miss. So when you think about the healthcare field and you think about the inequalities in the healthcare field, this is one of them, right? Is if people aren't being taught what it looks like in someone who has a darker skin tone, that you may not be able to see pink or red or yellow, or if they're having cancers that are popping up, that generally when you think about this cancer, it's in, the trunk or in a mole, but now all of a sudden you're seeing it in another population where it's coming in areas that aren't told or taught about, then you can miss that. And that can lead to higher death rates, because melanoma is really bad. You need to catch it early to be able to treat it successfully. If you do not catch it early, that's the reason for some of the really high death rates for this, is because it metastasizes before a lot of times people are able to even identify that they have it. So the ABCDE rule. And so what they're talking about there is, when you look at these growths, or even if you have a mole, you need to see, is the mole, does it have asymmetry? If it's nice and good and round like this isn't what we're looking at. We're looking at something that tends to not be this nice circular object. Look at the boundary or the border of it, right? Is it irregular? Look at the color of it. If you do have a growth that you've had from your kid, right, some kind of tag or mole or whatever, and then all of a sudden it starts changing color on you, that's an indication that maybe you need to get it checked out. D is for diameter, right? Anything bigger than about 6 millimeters, which is the size of a pencil eraser. You might want to get checked out. And is it changing, evolving? So if you have some kind of growth tag mole and it significantly starts to change, i.e., what do I mean by that? Is it starting to become elevated? Above the skin, is it starting to itch where it never itched before? Is it starting to look scaly? These are things that you can look. So people at any age can get these, right? So let's talk a little bit about skin cancer and some facts. So skin cancer is considered one of the most common cancers. One in 5 Americans will develop skin cancer by the age of 70. So we're talking about 20%. More than 2 people die of skin cancer in the US every hour. Having 5 or more sunburns doubles your risk for melanoma. And when detected early, and this is why I harp on what things look like so much, the 5-year survival rate for melanoma is 99%. But let's talk about that in terms of ethnicity and race. Because when you look at the estimated 5-year melanoma survival rate for Black patients, it's only around 71% versus 94% for white patients. And I firmly believe this all goes down to not knowing what the signs are, right? So when we look at skin cancer, it represents about 2 to 4% of all cancers in Asians, 4 to 5% in Hispanics, 1 to 2% in Black individuals, and mostly for people with darker skin tone, Black individuals, Asians, and Native Hawaiians. It most oftenly occurs in non-exposed skin that essentially has less pigment. And so 60 to 75% of those tumors arise, like I said, on the palms, soles of the feet, and nail regions. And for people that have darker skin tone as well, the foot is probably one of the most common sites of skin cancer. It's involved in about 30 to 40% of all cases. And so that's why it's so important to be able to identify these, right? And you can also see it in children. It's not just an adult disease. And so in children and adolescents, it's a small percentage of new cases, but there are about 300 cases a year for children under the age of 20 for melanoma, right? And it accounts for about 3% of all pediatric cases of cancer in the United States. And a lot of times, you get a delay in treatment because people misdiagnose pigment lesions somewhere around 40% of the time in kids. And so this can cause severe issues with treatment and survival rates. Now, when it comes to age, they are expecting, as we go through, melanoma cases or diagnosis will increase by 7.3%. This is specifically for 2024. And so as we go through here, it's like the number will rise, and that's a combination of increased exposure, but also better diagnosis. They do expect the melanoma death to increase by 3.8% in the US. So that's it's sad to continue to see this, but it is a pretty aggressive and generally a later diagnosed condition. In the past, the good news, in the past 10 years, the new invasive melanoma cases, they've actually been able to diagnose them better. So that's one positive, but the number of cases have increased severely. So they expect about a little over 8,000 people will die of melanoma. And just to let you know, there is a gender difference here. More men actually, they see die and get diagnosed with melanoma than women do. And so when we look at this, 6% of the new cases are diagnosed in men for melanoma and 4% are for women. And so men age 49 and under have the highest probability of developing melanoma than any other cancer except for colon and rectal cancer. And from ages 15 to 39, men are 55% more likely to die of melanoma than women in that exact same age group. Now, women age 49 and under, they're more likely to develop melanoma than any other cancer except breast and thyroid cancers. So it's in the top 3 for each gender. So that's why we kind of talk about this. And I do hope that this has kind of brought some insight into melanoma and skin cancers in general, and to help to protect yourself against these things or your family is moving forward.